think it's appropriate to do it at this moment.
Okay. All right, then, do you want to do exhibits, Judge?
I am.
Oh, great. Do you mind if I sit?
That's fine.
Okay. So we would like to look at 3227, 144. This is an Instagram photo taken on February 9th, 2016, and posted by Maya.
3227, what number?
144, 0144.
Can you pull it up, please?
Yeah, February 9th, 2016. Judge.
Objection, relevance. I think we faced a number of cumulative objections for trying to introduce photos of Maya Kowalski, so I'm not sure what this adds to the case.
Well, if I need to respond, I can, Judge.
Sure.
It adds several things. One, it is 3 days before she is in Dr. Barr's office saying that she has pain that is like fire throughout her entire body. Secondly, it shows that her ears are pierced, which goes to several people testifying that piercings would cause pain with RSD. And it shows no lesions on the skin. And I don't think we've put in many photographs at all yet.
It does nothing to establish if she had her ears pierced recently or this exists. I think it's since she was 4 or 5 years old, so not sure what that adds.
And I don't think touching her earring
Check.
is particularly painful.
The court will receive into evidence 3227-0144. But let me ask you this. All of this metadata at the bottom,
We can delete that. I want the date on it, but we can delete the metadata if you want.
I mean, does the plaintiffs care? I just want to.
Right, we did delete some of it, but I'm happy to delete all of that, Judge, as long as the date remains.
We don't have any objection to the metadata.
Okay. The next one would be 3227-0135. The significance of this photo, Judge, is that this is the day after she's in Dr. Barr's office saying that her pain is like fire throughout her body. I think the jury should be able to see the photograph the next day, which would indicate no, plus there are no lesions visible on her skin.
Objection, that is absolutely not the purpose. They are going to attempt to make the jury believe, I don't know what about Maya in that pose, but we assert 403 on that. Any probative value is far outweighed by the prejudice of attempting to show this young girl as anything other than a young girl.
Judge, this isn't like surveillance. This is a photograph she took of herself and posted on Instagram. It's the day after she was in a doctor's office telling them she has pain throughout her entire body like fire.
The court will receive into evidence 3227-0135.
Thank you. 3227-0485. This is taken on April 23rd, 2016. Shows her wearing a metal bracelet around her wrist and her hand and no lesions.
Don't we all, cumulative, Your Honor, don't we already have not only testimony but other photographs?
Okay, I'll let this one in, but Ms. Quarles, we're getting to the point where,
That's fine, Judge.
I mean, we almost have a family photo album of probably about 40
Well, I
or
did-
50 pictures by now.
I did try to pick different dates, Judge. I do have one more along those lines, though, that I'd like the court to look at.
Sure.
That is 3227-0441. The significance of this photo is that this is July 16 when she's in a wheelchair. You can see that she is sitting on the edge of a table of some sort, raising her left leg. And this is when she is in a wheelchair. Time frame.
Objection, this is again cumulative to about 7 or 8 other photos and indicates what? That she can sit in more than a wheelchair? What is it probative of, other than just some kind of prejudice
This is,
about the, I don't understand.
this is when she's in, isn't this when she goes to the hospital? This is during Dr. Hana's treatment.
Sitting
She's
there.
in a wheelchair, supposedly. She can't move her legs.
She's
This
fine.
is a photo taken on July 16th, 16. She's sitting with her own body without any support on a hard surface, not in a wheelchair.
Don't we have video of her playing around in the pool and demonstrating her upper body strength based
This
on
is-
the ketamine infusions, based on where she was with her therapies?
I'm gonna let in 3227-0441.
Thank you, Judge.
And cumulative, by the way.
Listed this one. Number 3089, I think we just, are you able to play that? Great.
Cumulative to other ones and does not demonstrate anything other than what is already in the records. Yes, she can play the piano.
Well, the other piano one was not during the admission of the hospital. I don't remember the date, but I know it wasn't during the hospital because it was at home.
Yes.
I'm gonna admit, what number is this?
3089.
3089, the court receives.
32320819.
3233. Let's go ahead and put it up, whatever it is.
It's a blog by Kowalski, dated 8/10/2015. We were going to redact the comments above and below, Judge. I thought that had been done, but so it would start at user Beata Kowalski, and then the text, and then the date at the bottom.
Didn't I just let in yesterday a whole series of emails from Beata Kowalski over any number of dates?
Those were all I thought about all about the coma. This is
Well, no,
August 10th.
I mean, there were lots of them because they went not only during the November of 2015, but they went all the way almost
Okay, well, I'll
in
withdraw it.
2016.
Let me take a step back from that, Judge, and look at what was admitted before we go to this.
Because, I mean, there's a cumulative issue.
Yeah.
I let in a whole bunch of them.
All right. Let
Yesterday.
me see if I can find that, Judge. Okay.
Well, if you're gonna cry, I'm not gonna.
I think
Judge,
he's talking to Mr. Whitney.
I'm sorry.
He is.
Yes, we're
We're having a moment, sorry.
Very mad at me, I didn't ask questions. He wanted to correct.
Okay.
Never mind.
It's just, if you all want to talk to each other, you really need to push the silence button. And
I understand.
I mean, we all hear
Me.
when you know
Including the
you,
jury.
yeah, including like doing this with your fingernails, like I just did, and all sorts of other. Moving the microphone like that doesn't really do it. You need to hit the mute button and hold on to it when you want to have that discussion. I see the TV gentlemen probably would be very happy if you did that. He's shaking his head yes.
Yes, sir.
What's next, Ms. Crows?
Judge, we would like to revisit 31389. That was the Tribeca Film Festival, and I'd like to clarify with the court that the photo you left in as 7 was from 2022. We removed all references to Tribeca, so it is simply the 2023 photo we have. The previous one of her with her boyfriend is from 2022, where it looks like she's going to the prom or something. If you can see, we've removed all references to the Tribeca Film Festival. That was the prejudice that was claimed. It is a 2023 photograph of her with her boyfriend.
I maintain my ruling on 3138-009.
I'm sorry?
No, I'm not reconsidering. It's not in.
Yeah, Judge, I think that's our only 2023 photo. Okay. Right?
I mean, obviously, in 2023, the jury has seen Maya Kowalski here. I'm just saying.
I think the testimony of Maya Kowalski with respect to her life has been dramatically different than that photo. Although she acknowledged she had a boyfriend, she only goes over to his house, they don't do anything. I'm suggesting, Judge, that in fairness to the defense, we should be able to present other aspects of her life that have not been testified to in front of this jury.
Tribeca film photo is out.
Okay.
What's next? We're getting close to 1:30.
Okay. All right. Well, there's nothing else that needs to be confronted today, Judge.
Are we, anything else we need to talk about? Witness, Mr. Anderson, before we bring him in?
Judge, we would move to strike the opinions having to do with standard of care based on 90.704703 on the fact that from the evidence, the witness conducted virtually no independent analysis of the evidence in order to render such opinion, and therefore both the foundation and the predicate of this were lacking, and thus there was no basis for those opinions rendered.
Well, I think the jury can make the determination based on the questions that have already been asked, and I'm sure will be asked.
Yes, sir.
Only other thing, Your Honor, is...
So we're back to tag teaming again?
No, I'm not arguing the issue.
Oh.
I'm bringing up witnesses for tomorrow. We only know Dr. Smith.
Nurse Alicia Alcida.
The nurse that assists with the photographs.
I'm not sure I'm saying her last name
I know who
correctly.
you're talking about. And who else?
Those are the only two live witnesses, hence the need for depositions.
Understood. And we're done designating Dr. Hannah counter-designating, so.
Okay.
And so at some point, when do you think I will be able to receive the objections? And I might or might not. Did someone send the actual deposition over? I know I got something for Dr. Hannah a few minutes.
I'm sure they weren't highlighted, Judge, with designations, if that matters. I don't know if you need it highlighted. We're just going to give you our objections.
I just need what I'm supposed to rule on and the
Okay.
deposition, hopefully the full-size deposition. And I'll take it from there.
Okay,
But I just need that information.
understood.
Anything else about anything before we bring in the jury?
No, just procedurally, Mr. Anderson, are you done with your cross?
I am done with my cross.
I have just a couple minutes of redirect, and then we'll yield to jury questions.
Okay. Let's bring in the jury. Let's go get witness, Mr. Anderson.
Members of the jury, I want to confirm while you were away, you did not discuss this case amongst yourselves, you did no investigation, and received no information. Is that all correct? And no one approached you about this case. Is that correct? And you did not see any media coverage about this case. Is that correct? Mr. Shapiro, it's your turn, sir.
Mr. Anderson, just to clarify the sequence of events, last night you and I met, is that right?
Right.
Okay. You gave me your opinions,
Correct.
and then I discussed with you what topics I'd like to cover in front of this jury, is that right?
Correct.
I gave you an outline of the topics that I wanted to cover, is that right?
Correct.
I didn't tell you what the answers needed to be, did I?
No.
Okay. The answers that you're giving to the jury today are your own.
Correct.
Objection, leading, let it go a little bit.
So staying on this issue.
Okay. The answers that you gave to the jury, where did they come from?
They were from my own experience and my own observations of the data that I read.
Okay. And I know that at this point in the trial, you're one of several experts that the jury has heard from. But in your experience serving as an expert, is there anything unusual about meeting with the attorney the night before?
No.
Okay. You were asked about a performance review of Miss Betty. May I approach the witness with the document?
Show it to Mr. Anderson.
Yes.
Attorney Mr. Anderson, I should say.
If I may approach.
Yes.
And take a moment to read both pages, if you wouldn't mind, Mr. Anderson. Is this the two-page document, the full document that you had discussed with me earlier about you being aware of one verbal write-up?
Correct.
Okay, so I had provided that to you before testifying.
Correct.
Let me ask you this. In reviewing the document, does that show any impropriety with another patient, or was it employee to employee?
It was employee to employee.
You were asked about any notification from the family about Miss Betty's conduct. Do you remember that testimony? Mr. Anderson had asked you if the hospital ever received notification about the family complaining about something Miss Betty had done. Do you remember getting that question?
Not in the way you're.
There's no, in your review of the record, was there any notification from the family complaining about Miss Betty regarding any improper touching or stroking or anything of that nature? Okay.
No.
And finally, regarding, just briefly on the joint commissions, the accreditation body for hospitals, in your experience as a hospital executive officer, is that a requirement for hospitals to participate in federal funding programs?
The Joint Commission is a volunteer activity. If they choose to go through it and are accredited, then they are enabled to bill for federal funding.
And from your review of the materials you have, either publicly available or otherwise, did it appear that all children's had participated in that program?
Yes.
I appreciate your time.
Mr.
No, Your Honor.
Anderson. Members of the jury. Have I got them all, or are there any more coming? Looking at the number of questions, why don't you all step back? Do not discuss this case amongst yourselves. Do not do any investigation and receive no information.
All right, for the next thing. Jurors entering.
And Mr. Witness Anderson, or Witness Mr. Anderson, let me ask the jury my questions. I want to confirm while you're away, you did not discuss this case amongst yourselves, did no investigation, and received no information. Is that correct? No media?
Correct.
No contact?
Correct.
Okay. And Witness Mr. Anderson was outside the presence when I went over these questions with the attorneys, so this will be the first time he's hearing them. Mr. Anderson, if the hospital had all of the proper protocols in place and periodic department reviews, would a patient or patient's parents' complaints about a specific employee be documented and reviewed by supervisors, especially if the complaints were multiple?
Yes. When the parents make a complaint, it would go through whoever they complain to. If they're complaining to a physician, go through that process with an employee the same. But it would be looked at and followed up through HR and with the employee if there was an official complaint.
Are only performances observed by other staff and peers of an employee documented for review? I think this question follows that last question.
When behavior is looked at as well as complaints or anything that might come to an attention, but a review that is conducted is really the observations of the supervisor, any external comments from other departments, and then the 360 review, where there is commentary from the peers of the employee.
Did you see a letter from Beata Kowalski about action of some of Johns Hopkins All Children's Hospital's employees in the care of Maya Kowalski? Do you want me to read it again?
Of patients other than Maya?
Let me read it again. Did you see a letter from Beata Kowalski about action of some of Johns Hopkins All Children's Hospital employees in the care of Maya Kowalski?
I do not recollect that, no.
Do you know the name of the supervisor that did the review of Miss Beatty, and does she still work at Johns Hopkins All Children's Hospital?
I believe the name of the supervisor who did the review is Chris Drisdall. I'm sorry. Get it out. I have no idea if the individual is still at the hospital or not.
Do you believe the 2-day surveillance was done with the right intent, given the statement made between Doctors Dees and Smith that, quote, a 10-year-old can't keep up the charade 24/7, end quote?
I would set aside the comment and answer that I think there was an exploration of a diagnosis that was still being explored, that of is there abuse, so that there was justification for the order.
How many disciplinary meetings were there, and what were they about?
I don't understand that.
I'm assuming the context is Kathy
Kathy
Beatty.
Beatty?
Yes.
I think from the documentation that I see now is, I think there are two. Is what's referenced.
Did you say the pictures taken were to look for child abuse?
I think that was part of it. I think there is in John Hopkins, if there was an examination to look for abuse, then that was part of the reason for the photographs. But I also think that it's my understanding that if an individual is to make a court appearance or to leave the hospital, there are photographs taken at that time as well.
The photos were taken in January, which is 3 months after Maya was checked into the hospital. You're aware of that?
Not the specific date.
Why did you not review the Joint Commission reports?
The Joint Commission entirety of the report, or reports, is what I was making my comments about was that the hospital had been surveyed and had been accredited. And I wasn't referencing having seen the report. I was acknowledging that they had gone through the process of evaluation by the surveyors and that they had received accreditation for their performance and review.
This is a little bit lengthier question. I am a bit confused as to the reason for the photos you stated. By past witness testimony, I thought the reason for photos when Maya was in her skivvies was before court, and past testimony said another set was taken upon return from Maya's court appearance. In order to document any, quote, new, end quote, body marks while not in the hospital's direct care. In your testimony, you said the Maya disrobe for photos was for, quote, diagnostics, end quote. The, quote, provided documents, end quote, you were provided and reviewed something photos taken this date of Maya to be used for diagnosis or for comparison? Or do you recall what you read that made you testify the photos were, quote, for diagnostics, end quote?
What I was referencing that I had seen in the documentation was the request for photos by Dr. Smith and Dees. And that was to assist in the pursuit of the diagnosis of whether or not that was contributed to a diagnosis of child abuse. That was the referencing that I was making.
Mr. Shapiro, do you have further questions?
Not at this time, thank you.
Mr. Anderson. Attorney Mr. Anderson.
So you agree that senior hospital management were kept informed regarding Maya's care and treatment between December 2016 and January 2017, right?
Could you repeat that again, please?
You agree that senior hospital management then knew about Maya Kowalski's care during her stay there?
I don't know specifically which senior leaders knew of her stay there. What I was saying in my testimony was that it's very common that there are multiple shelter orders in place, and that senior leadership would not necessarily intervene on those cases as long as the care of the patient was proceeding and was not rising to a level of crisis. Patient was stable. That was my reference in terms of indicating why or why not certain individuals might know of Maya's condition in the hospital.
So is your answer yes, you just can't tell us which senior official?
Well, Mr. Anderson, I can't tell you which senior officials knew.
I
don't
understand.
know.
We're speaking the same language. I'm saying, are we in agreement that in your opinion, senior management knew, you just can't tell us which one of the senior management? Are we in agreement about that?
I believe that there were senior managers who did know, but I don't know who they were.
Thank you. You've never seen any indication of any review of Ms. Beatty's conduct outside of the corrective action I showed you, right?
Not from Ms. Beatty.
Right. So all of the actions I was talking to you about, in other words, the photography, the sitting on the lap, all those, you never saw anywhere in the records any corrective action as to Ms. Beatty, did you?
No, because I saw no official complaint lodged about any of those activities.
That's not my question. My question was, did you see in your review any indication that anyone at Johns Hopkins took any action regarding that?
No, I did not.
And as to the photos themselves, 48 hours as well, if they were going to be for diagnostic purposes, you would expect to see some medical analysis of them, would you not?
There should have been a review, yes.
And they should have appeared in the medical records, one would think.
That would be the logical place to see them.
Thank you.
Mr. Shapiro.
To be clear, Mr. Anderson, having reviewed the sworn testimony of Ms. Beatty that we did provide you, she denies the allegations against her, does she not?
Yes, she does.
And in terms of your review of what was provided to certain levels of leadership, is what I understand your testimony to be that there were members of risk management that were consulted about certain legal obligations?
That's correct.
Do you know whether those people in risk management were at senior leadership or executive levels versus lower level risk managers?
I do not.
Action leading.
Do you know, as you sit here today, what the level of executive leadership was that were consulted on those questions?
No, sir, not all of it, no.
Okay, thank you.
Anything further, Mr. Anderson?
Can we put up trial exhibit 2277-628A? 2277-628.
Is it in evidence?
Yes.
It's in evidence.
Then you may.
While we're waiting, do you know who Jackie Crane is?
I've seen the name on the organizational chart of John Hopkins and knew she was the senior counsel.
Does this exhibit show a copy to Jackie Crane?
Yes, it does.
And at the bottom there, not the next to bottom after a lot of the whiteout, does it advise a doctor to get pictures of the scratches?
Yes, it does.
Right. And when you explained before on that flow chart, that organizational chart, Jackie Crane was directly linked to the president, correct?
She has a reporting relationship to the president.
Nothing further.
No further redirect. Thank you.
And members of the jury, do any of you have, it looks like we have further questions. Let's see if we can do that just up here without having to send everybody to different locations. Okay, doctor, this is actually my question, not the jury's question, but in your testimony a few moments ago, did you say exploration of a diagnosis or expiration of a diagnosis?
Exploration.
Exploration, okay. At this point, I'm not going to ask that question. Next question. Do you think Johns Hopkins All Children's Hospital needs to change their policies for patient and safety care?
From the records that I saw, from the chart that I saw and the way that they have organized the hospital, their framework for managing safety issues, patient care issues is there. From what I saw in the record, there is internal communication going on daily on a real-time basis relative to patient's care. So I believe that Johns Hopkins does have appropriate models for the safety of their patients.
Mr. Shapiro, anything follow up?
No, thank you.
Mr. Anderson, anything further?
Have you seen the testimony of Drs. Perno and Napolitano about the lack of such day-to-day review?
Objection, mischaracterization.
Overruled. You can answer.
There are structures that exist that departmentally safety items are involved. What they were referencing was their particular involvement in some of those activities. But there are, through the different medical staff committees and through the department structures, there are avenues for quality care to be done and to be monitored.
I just asked you whether or not you were aware that both of them testified about that.
Same objection, mischaracterization.
They both testified about that to my knowledge.
Nothing for you, Ron.
Nothing further.
Okay. Mr. Witness Anderson, you're free to go today, although you're still under subpoena and we may need to call you back. Okay? Good. Thank you. Defense, who's next?
Defense calls William Cecil, Doctor of Physical Therapy.
You solemnly swear or affirm the testimony you're about to give will be the truth, the whole truth, and nothing but the truth.
I do. Right this way.
May I please report?
Yes, sir.
Good afternoon, sir. How are you doing?
I'm good. How are you?
A little tired, but other than that, I'm okay. Thanks for asking. Could you please introduce yourself to the jury, please?
Yeah, my name is Dr. William Cecil. I'm a doctorate of physical therapy.
Can you give the jury the benefit of your education and training, the type of certificates and colleges and things of that nature that allowed you to become a doctor of physical therapy?
Sure. I did my undergraduate degree at the University of Florida, graduated in 2007, and then I then went to physical therapy school at Nova Southeastern University, where I studied for 4 years, including clinical internships in various settings, and graduated with my doctorate of physical therapy, and then sat for the Florida licensure exam.
Could you please explain for the jury what it is that a pediatric doctor of physical therapy such as yourself does on a day-in, day-out basis, recognizing that many of our jurors probably aren't doctors of physical therapy?
Sure. So I work in an inpatient setting, which means I'm in the hospital working with children with various illnesses. On a daily basis, I can help a child with cancer, and then a kiddo after a heart surgery or after a trauma, car accident. And my goal with each one of these patients is to help them recover whatever function they've lost, help them to identify what those weaknesses are, those abilities that they've lost based on their situation, and help recover that back to their normal baseline function.
Mr. Cecil, why is it that you chose to go into pediatric physical therapy as your calling?
I've always loved working with kids and families. Before I even thought of doing physical therapy, I worked for the YMCA, doing before and after care programs, working summer camps, worked for that organization for several years. I just love that dynamic of helping kids and then also working with kids and families to make that child's life better. So I took that experience and kind of parlayed that into my career, going into physical therapy, where you're not only helping kids, you're not helping kids academically, but you're helping them physically recover from a tough situation, whatever that may be.
Could you please give a brief explanation of your past employment history, places you've worked, things of that nature?
Sure. So I worked for the YMCA, as I said. After physical therapy school, I worked at a small outpatient clinic with adults for about 6 months, and then I was hired at Johns Hopkins All Children's. I had a clinical internship there prior, and I've been employed there ever since.
And approximately when did you start at All Children's Hospital?
I started at Johns Hopkins in 2015, and I've had continuous employment with them since.
And what is your current position?
I'm an acute care physical therapist.
And what was your position or title at the time that you came to care for Maya Kowalski back in October through December of 2016 and into January of 2017?
It's the same as it is now, acute care physical therapy, doing the same job, same general populations.
Could you give the jury a brief description of your work experience within your career with complex regional pain syndrome and other amplified pain disorders?
Sure. Over my career, most of that at Johns Hopkins, I've had significant experience with CRPS patients in chronic pain. I'm one of the primary therapists in our CRPS program, who's worked with dozens of CRPS and chronic pain patients over that period. Doing various, during different programs, even when I worked outpatient for a short period of time, saw patients in that setting also. So since I started Johns Hopkins, I've had the privilege to work with many patients with CRPS.
Now, my understanding is Johns Hopkins All Children's Hospital currently has a CRPS chronic pain clinic. Is that correct?
Yes, that's correct.
And about when did that program launch? Approximately.
I am not sure. I'm not sure exactly on when it started, but on the inpatient side, so we use our outpatient clinic and our inpatient facility as part of that program. I work on the inpatient side, so I'm not sure on the outpatient side when that exactly started.
And at the time you cared for Maya Kowalski, did Johns Hopkins All Children's Hospital have a CRPS clinic at that time?
No, sir.
Okay. Do you notice any difference with the way that you treated Maya Kowalski back in 2016 with the modalities that you currently employ with the CRPS clinic at Johns Hopkins?
Sure. So reviewing the notes from Maya, everything I did with her back in 2016 are the same types of treatments that we use now. Any patient who has CRPS, the goal of the physical therapist is to assess the deficits, find what's hard for them to do, and then come up with a treatment plan to improve those deficits. And the strategies we use then are the same exact strategies we use now. Nothing has changed.
Now, the jury's heard some testimony that complex regional pain syndrome is a regional syndrome. What does that mean to you as a doctor of physical therapy?
Objection,
Regional.
beyond scope, improper foundation, predicate as to medical diagnosis.
Overruled. You can answer.
So regional for me would indicate kind of one area of the body, one location, whether it's a leg or an arm, not a global full body syndrome or experience.
Now, I'd like to take you back in time to October, November, December of 2016 and into January of 2017 and your care with Maya Kowalski. Do you have any recollection as you sit here today of your treatment of Maya Kowalski?
Yes, I remember Maya well. She was easy to get along with. She was very pleasant whenever I worked with her. Some things that come to mind is like there's very distinct inconsistencies with how she participated and presented during her therapy sessions. Oftentimes she would refuse to do certain things that she did days before or in previous sessions. And we had a hard time, I had a hard time educating her. She was very resistant to any education I tried to provide to her on what we're doing, why we're doing it, trying to explain the importance of physical therapy.
Now, the jury's going to have an opportunity to look at some of your notes today, and all of your notes will be in evidence as well. I see here that you personally provided 21 sessions of physical therapy over approximately 20 hours. Does that comport with your review of the records?
That sounds correct.
Okay. And I believe there was somebody else in the PT department that also handled some of Maya Kowalski's consults as well?
Yes, sir.
Do you recall who that individual was?
Her name's Elizabeth Harper.
But fair to say you handled the majority of the PT sessions during Maya Kowalski's hospitalization at L Children's?
I believe that's correct.
Why don't you tell the jury a little bit about your relationship that you had with Maya Kowalski over the course of those 21 sessions?
Sure. Like I said, it was very, very pleasant. We would, I would enter her room and talk to her, kind of see how she was doing that day. We would talk about what the plan is for that day. I would give some goals, things that I would like to see her do. Oftentimes she would kind of push back on that, and there's things that she refused to do frequently. But we worked together as a team trying to achieve some goals that I had said and we had discussed together to improve her function. Never pushing her to do things that she was ever uncomfortable with or things that she never agreed to. But coming up with that plan together, which is really an important role for the physical therapist, right? We need our patients to buy in and build rapport with us so that we can make improvement over whether it's a short period of time or a long period of time.
Now, when you started out with Maya Kowalski in October of 2016, did you formulate a kind of a game plan moving forward for the course of your physical therapy treatments with her?
Yeah, so initially, I wasn't the one who performed her initial evaluation, but reviewed those notes, kind of saw what she was able to do at that point. And in your mind as a physical therapist, you're always assessing. You're always trying to find those weaknesses, find where we're improving and where we can make steps forward. So that with an eventual goal of being able to get back to normal life, whether that's walking or running or participating in activities. So you come up with a game plan, maybe initially, but every single time you see that patient, you're reassessing, you're re-examining that patient and seeing where they are that day compared to the previous days.
And so, if I'm understanding your testimony correctly, you're literally assessing on a session-by-session basis and tailoring your treatments based on what you're observing in real time?
Yes, sir, that's correct.
It's not a cookie-cutter approach?
Objection, leading.
Sustained.
How would you characterize Maya Kowalski's trajectory and improvement over the course of the 21 sessions that you provided?
Sure. So if you look at her initial evaluation and the documentation and then the final PT note, there are some areas of significant improvement. There are really three areas that we worked on every single time. One was her sitting balance. When she was first evaluated, the documentation shows that she required min to mod assist, which means she required 50% effort from the therapist, and she provided 50% of the effort just to maintain sitting. Not doing any activities, not reaching for the remote or anything like that. 50% help just to sit for 2 minutes. By the end, when she left the hospital, she was able to sit in her wheelchair completely independently, no back support, no arm support, and participate in activities, whether it was a game, whether it was piano, whether it was grabbing things from the floor. She was able to do all those things by herself. So that was one area that was improved. Another area that improved was her posture. especially her sitting posture. On her evaluation, she was in this slumped posture, unable to hold herself up, and complaining of back pain whenever she straightened up. Throughout the admission, she consistently had an upright posture, able to hold herself up with a straight spine, and no consistent complaints of back pain during that time. The third area was her activity tolerance. So again, on that evaluation, all she was able to do was sit on the side of the bed with 50% support for 2 minutes. That's all she was able to do. Throughout the entire admission, including at the very end, she was participating in physical therapy activities for 45, 60, sometimes 75 minutes with minimal complaints during our session. So all three of those were significantly improved from what her evaluation on that very first day we saw her was.
We're going to talk about this when we talk about some of your notes with the jury, as well as watch a video. But one of the things I think I heard you talk about was this concept of dynamic sitting balance that you saw improve over time. Can you tell the jury what the concept of dynamic sitting balance is to you as a PT?
Sure. So when talking about sitting balance from a physical therapy perspective, there are two things we need to consider. We break it into two parts: static sitting balance and dynamic sitting balance. So static sitting balance would be just sitting, not doing anything. How well can you maintain your balance sitting with no supports, not doing anything? Dynamic would be adding in any external stimulus. So playing a game, reaching, swaying our body back and forth, reaching to the ground, even providing external stimulus, so like throwing a ball back and forth. That impact of the ball coming to you requires you to use your core to maintain your sitting balance, or else you're just going to fall over. So that's the difference between, we have this static balance and we have this dynamic balance.
Now, early in your testimony, you mentioned that there were sometimes some inconsistencies with some of the things that Maya would report she could or couldn't do. What did you mean by that?
Sure. Oftentimes I'd ask her to do something such as help me sit her up in bed, or let's sit and put our feet on the ground and reach to play a game. She would often say, I can't do that, or push back and resist, or say it'll be too painful. But then moments later, whether we're in conversation or we're playing a game or she's being distracted some other way, you would notice her feet on the ground. She'd be sitting up straight by herself, not leaning over a wheelchair, having zero difficulty doing any of that sitting balance task.
I'd like to draw your attention to what's been entered into evidence as Joint Exhibit 1001, 1905 through 1906. And while we're waiting to get that up for you and for the jury, I'll represent to you that this is a physical therapy progress note from November 30, 2016. Fair to say you've had an opportunity to review this document fairly recently?
Yes, sir.
Do you see here on the first page, the 1905 page, where we'll highlight there just for the jury that it says November 30, 2016? Well, I guess they'll take my word for it. What I'd like to do is highlight the section here on 1906 that under general objective. Do you see where we're going to highlight here for you where it says patient? Patient refuses to participate in any therapeutic activities in the rehab gym this date. Do you see that?
Yes, sir.
Okay. Take a moment to read the highlighted passage for me. I'm going to have some follow-up questions for you, okay? You can continue the highlighting for another couple sentences, please. All the way through to unable to repeat. So, Mr. Cecil, I wanted to ask you about this. Is this an example of the type of sitting balance inconsistency you were talking about earlier in your testimony?
Yes, sir.
Okay.
Objection, meaning.
Sustained.
Can you please describe for the jury what it is that we've got highlighted here and how it ties into your treatment of Mike Kowalski as well as your observation of inconsistencies?
Sure. So she refused to participate in things at the gym. That was the gym, the physical therapy gym, the inpatient rehab gym. It's a place we take most of our patients who are able to leave their room, that we have functional goals for. So in the gym, we have items like practice stairs, we have play mats, we have parallel bars that help retrain people to walk. We have other specialty equipment. So that's why we typically go there, because it has all of our things that we like to use to help improve our function. This day, she happened to refuse. We had a conversation that the benefits of going to the gym, but she refused. So instead, we went down to the first floor where there's a piano. And while down there, she was able to play the piano without difficulty. So that involved sitting up straight, leaning forward, reaching forward, playing the piano without any loss of balance. No difficulty, no signs of distress, facial grimace, or anything like that. During that time, as it says here, I noticed that it says bilateral lower extremity, so both of her legs were in near full extension with controlled movement. What that means, that's kind of fancy medical terms for, she was kicking her legs all the way straight, or near all the way straight, which is something that she had said consistently she couldn't do. So this was something to take note of, because it's something that we rarely, if ever, saw happen. So she was kicking her legs nearly all the way straight in a controlled motion. It wasn't just kind of flopping all over the place, which would indicate, poor muscle tone or poor strength. But it was a controlled motion, kind of all the way into extension or near extension, and then back down. The next sentence, as it says, when I brought attention to this, because I wanted her to know, hey, look, you're doing this. Your legs are moving. Like, we can parlay this. We can use this to progress into more strengthening for your legs, into some more movement that's going to make you more independent at home. When I did that, she immediately was unable to repeat. She stopped moving her legs altogether, and we didn't see that again on this day.
And why is this significant to you as a doctor of physical therapy, what you're describing here for the jury?
Yeah, this is significant because she consistently, this was November 30th. This is already a month or more into seeing her. She had consistently, every single day, said she can't do things like this. And during our sessions, we try to get her to participate in activities that are going to strengthen her legs in order to become more functional, which was refused most of the time. So being able to see her do this with no visible signs of pain was significant.
I'd like to now pull up a video for you. It's been marked in evidence as 3089, please. And why don't we watch that together, and I'll have a few follow-up questions for you, okay? And I'll represent to you this is a video from the lobby at Johns Hopkins All Children's Hospital. So, Mr. Cecil, I'd like to ask you, just as a doctor of physical therapy watching that video, what stands out to you as significant that might help this jury?
Yeah, there were several things. So the first thing that you look at, if you look at her posture, she's sitting up straight. She's scooted forward in her wheelchair off of the back support. So she's not using the back support to help her stay upright. Also, her arms are not on the armrests. She's forward on the keys. So she's using her core and back muscles to maintain that posture. That's the number one first thing. Secondly, at the very end, you kind of see her move to the side. She's moving the wheelchair. No one's pushing it. She's moving it to the side, kind of using her hands. And if you look closely, she actually moved her legs to help move her wheelchair to the right. Her toes and the balls of her feet, kind of the knuckles of her feet, are on the ground the entire time. And she's smiling at a point. She has a smile. So it's significant that her feet are on the ground, her legs moved, she's smiling, which is things that she verbally said that she was unable to do. And when asked to do things similar to this, completely refused and said it was too painful to perform those activities.
Now, the jury's heard a little bit throughout this case about the concept of distractibility. Do you know what that is?
Yes, sir.
Can you please explain what that is for the jury, please?
Yeah, so distractibility is a technique that all therapists use, especially with patients who are in pain. We try to make conversation or use games or crafts or other things to distract the patient from their pain in order for them to participate better in our therapy session. We're not ignoring their pain. We are using external items or games or things to shift their focus to something else.
Did you ever utilize any distractibility technique with Maya Kowalski? And if so, can you please tell the jury a little bit about your observations in that regard?
Yeah, every single session. Distraction was basically the only non-pharmacological, so no medication pain technique that we could use that was effective in helping her to participate better in therapy. So frequently we would engage in conversation, talking about music or what do you like to do or things like this. Or throughout my documentation, you see we're playing games, whether it's laying flat on her stomach on a play mat with her propped on her elbows playing a game, or sitting in a chair with a game in front of her, working on her posture, providing that external influence or focus to take her focus off of her pain and go towards participating more and more.
I'd like to draw your attention now to what's been entered into evidence as Joint Exhibit 1001-1900. And I'll represent to you that this is a physical therapy note from All Children's Hospital on December 3rd of 2020. Have you had an opportunity to review this note before today?
Yes, sir.
I'd like to draw your attention to the section here that says patients aren't visiting at gym at time of therapy session and remain present throughout session. Do you see that section of the note?
Yes, sir.
Do you recall anything about interacting with members of Maya Kowalski's family that came to visit at Johns Hopkins All Children's Hospital?
The only thing I remember is the aunt was present during this session, and then I think there was once or twice where our session was finishing, and I believe her father was in the room kind of waiting for her to return back. So I would drop her off back to the room, and her father was in the room at that time. That's the only time I remember seeing any family.
And I'll draw your attention to some highlighted portions here under assessment and goals. And while that's getting pulled up, can you explain to the jury what stands out in your mind during this visit from December 3rd of 2020?
Sure. May I take a moment to reread it?
Yeah, sure. They're going to pull it up for you. There you go.
Yeah, so the big thing that stands out here is that with her aunt present during this session, her presentation was very different than previous sessions. In previous sessions, using our distraction techniques and kind of focusing on function, she was able to participate fully. She didn't have any issues with her balance or needing to lean side to side. Here, with family present, you can see she was leaning. So if we put her next to the parallel bars, which are these straight bars that help us teach people how to walk, she was leaning over across them the entire time. stating that she couldn't sit upright, she couldn't do certain things. But once we pulled out a game, so she was, I don't know if it was a card game or something, but it says she was doing in-hand manipulation, playing a game. So she had pieces inside her hand, playing a game. She was able to sit upright. She was able to participate without leaning on those bars. And then I believe it says after that game was over, she again started leaning on the bars again with no change of status, with no nothing in the session changed to require an increased level of support.
At any point, did you ever tell Maya that her pain was not real?
No, sir.
Would you ever do that with a pediatric patient?
I wouldn't say that with any patient. Whenever a patient tells me they have pain, I take that at face value, and we grade our exercises. We either grade up or grade down our exercises based on patient report and what they're able to tolerate.
Since we have limited time here, I'd like to get an idea of why it was that when Maya originally started out with physical therapy, she was doing sessions 6 times per week, and then as the hospitalization progressed, my understanding is she was cut back to 3 physical therapy sessions per week. Can you provide insight to the jury as to why that was?
Yeah, so we started 6 times a week because she had these large functional impairments when she first came, right? She wasn't walking, she wasn't propelling her wheelchair, she wasn't standing, all these things. And while that didn't change, the quality of her participation in therapy did change. She started participating less and less. If you look at the therapy notes from the beginning, she was willing to attempt standing. She agreed to try, and I believe she tried her best. And we would encourage her to keep working at it. That's how we're going to improve. But there came a time, I think, only a few sessions in, where she completely refused standing. So there came a point later on, I think it was in December, that the amount of improvement we were going to make with how much she was participating, we were kind of at a plateau point. We were doing really well on our sitting balance. She was participating in 60 minutes to 75 minutes of therapy per session. But she wasn't willing and wasn't able to participate in standing, attempt walking, anything like that. So we cut her back to 3 days a week with the knowledge of if she showed more participation, if she was able to move her legs, if she was willing to do those things to attempt standing, we could immediately increase that frequency back up to 6 or 7 or whatever was appropriate.
Over the course of observing Maya Kowalski over the sessions that you did you ever notice Maya Kowalski's feet in the anatomically correct position or in an inverted dystonic presentation?
To my recollection, I never saw them in an inverted dystonic position. They were always in a kind of relaxed down, pointed down position.
Were there ever any times that Maya Kowalski would describe her history of using pain medications with you during a physical therapy session?
There were frequent times when I would try to educate her on physical therapy, like what we do, why we do it, why physical therapy is a part of the treatment plan for CRPS. She was always very resistant, and she would frequently say, this treatment isn't going to work. Physical therapy isn't the treatment I need. I only need ketamine. That's the only thing that's going to work for me. And that she would say that was said multiple times.
And how would you respond when those types of topics would come up, when Maya would insist that ketamine was the only way to get better?
I would just continue trying to educate her on the physical therapy role on CRPS and how what we do is going to help her get better with her participation.
Did you ever see Maya Kowalski's legs in a position known as crisscross applesauce, also used to be known as Indian style?
Yes, sir.
Why is that significant to you as somebody in your field?
I would see them in that position frequently when I would pick her up from her room. Sometimes she'd be in her bed sitting in that position. The question that always popped in my head is how did you get in that position? Because she wasn't moving her legs during her time with me, very minimal movement, except for a couple of times as we saw in the notes. So I would think, I don't think I ever brought it up to her because she'd be very defensive, but I always wondered how you got in that position. Did you use your arms to get your legs in that position? Did you move your legs to get in that position? Then also, how are you tolerating that position? Because most of the time she would complain about this severe allodynia, which is sensitivity, severe pain to touch. She'd complain of severe pain to any touch to her legs. And I would wonder, so I would think in my head, like, this is one of those inconsistencies, right? She was able to tolerate this crisscross position with her legs on top of each other. But any other touch from a provider, including me, would cause severe pain complaints.
Do you remember any types of clothing or jewelry that Maya Kowalski used to wear? And if so, how is that significant to your observations?
She wore a variety of different clothing. I remember wearing shorts, pants, leggings, various things during our session, and the same kind of thing. Like, and if I tried to help her do a leg kick together, assisted, she wouldn't tolerate it. But this material on her legs didn't seem to cause a problem. So just another inconsistency.
Now, despite these inconsistencies, though, you didn't give up on Maya, did you?
Never. I never give up on any of my patients.
Why don't you tell the jury a little bit about the continual efforts you made, including all the way through towards the end of physical therapy with Maya Kowalski?
Sure. My goal the first time I saw her was to help her get better. I wanted her to leave our hospital walking. I wanted her to leave there walking, be able to go back to school, walk around school, do the activities she wanted to do. That's what as physical therapists, that's what we all enjoy, right? We got into the profession because we like helping kids get better. We like seeing them go from an injury or an illness back to a sports field or back to participating in school or whatever their passion is. So that was my goal for her all the way through. So using the therapy techniques, the exercises, the activities to try to help her get stronger and more active, that was my goal all the way through.
Now, at the very end of your 21 sessions with Maya Kowalski, in fact, I think it's one of the last, if not the last line in your charting, you noted that Maya, quote, displays functional strength to complete tasks, but when asked to perform specific activities, she actively presents with impaired function. That's a little bit of a mouthful, so why don't you break that down for the jury and describe what you're explaining there as you kind of finished up and wrapped up with your sessions with Maya Kowalski.
Yeah. Do you happen to have it on the monitor so I can reference it? Or?
I actually don't, but...
Can you say it one more time for me?
Yeah, she displays functional strength to complete tasks,
Mr.
but when asked...
Why don't we just hand it to him? Let's not read things and let's not read it twice.
Can I approach?
Sure.
Apologize, Joe.
Thank you. All right, so...
It's not my charting here, so I'll withdraw the question.
No more questions.
Hold on a second. If you all come up, please. Mr. Hughes, did you have any other further questions? Let me figure out the timing here. Do you all want to break? I saw several people stand up, so. Or do you want to keep going? Keep going. There we go, Mr. Anderson. You may go.
Have you ever heard of the term confirmation bias?
Yes, sir.
What is confirmation bias?
My understanding, confirmation bias is using the information in front of you to come to a conclusion that you desire or you perceive to be the truth.
It's where you're told something also by somebody else about a person, a thing, an object, and it's the lens through which you then view that person, thing, or object. Would you agree with me then?
That could be a definition.
And so when Maya came to you, a couple things were true, weren't they? First, she was only a few weeks away from her ketamine infusions, right?
I have no information on that.
Okay. And the second thing was that let me go back. On confirmation bias, were you told that Maya Kowalski was a victim of either conversion or some other psychosomatic problem?
To my recollection, when I first read through her chart, the diagnosis was CRPS, and I didn't have any other information other than that at the time.
Are you sure that your impressions weren't conversion disorder, deconditioning, and that through reading through her file there, you saw conversion disorder? I mean, not that you saw it physically, but you saw it in her file?
I don't recall seeing that in her file, but deconditioning can also be associated with CRPS.
All right. So at the start, she was just a few weeks away from ketamine treatment. You don't know about that. But she was also willing to do a lot of these activities, right?
At the beginning, she was willing to, agreeable to participate and attempt many things.
Right. But as time went on, she began to complain more and more that it hurt. Did she not?
No, sir.
Do your records not show that she's saying things like, I'm in too much pain today?
Her complaints were never more. They were always consistent all the way through.
Okay. Well, with all the stuff you've got as to her doing or not doing, you've got, of course, photos of this, right?
I have photos of
Maya Kowalski, like, doing all of these things, like being able to do them. I saw the video of her playing the piano, but do you have any photos of her being able to do things that she says she can't do?
No, sir, I don't have photos.
Do you have any videos of her doing things that she says she can't do?
I have my medical records that indicate things that I visualized and saw her do.
Okay. Well, we do. And before we get into that, did you get the same memo the last witness did?
I don't believe so.
Did you get an outline from the defense lawyers about what was going to be asked of you?
From the defense, yes.
Mm-hmm. When did you get that?
Yesterday.
And in there, they told you about some things to look for, right?
I don't know what you mean.
Well, they told you, I'm going to ask you about this, or you're going to be asked about that. True?
Yes, that's true.
Uh-huh. And in there, or, I don't know, maybe previously, they told you some things you could look through in your records and find, right?
No, sir. They gave me my records and asked me to look through them and be familiar with the things we did during that period.
Knowing the things they were going to ask you about, right?
I think it's prudent to have the information of what I'm going to be asked for.
Right.
Correct.
Well, this was towards a point, and you had been told from the start that you needed to look to see if there were signs of conversion disorder.
I was
Right.
never asked to do that.
Okay, well, can we put up 1002-0188? And at the bottom there, above chronic pain, we highlight that. Let's see. Now you got to go. Yeah, there you go. You see that?
I do.
How'd that conversion disorder get in there if you didn't know anything about it?
There must have been a change in the medical record from the physicians to indicate that they were leaning towards that diagnosis. So that goes into my documentation as a physical therapist.
Well, it's your physical therapy report, is it not?
Yes.
Are you saying somebody broke into your physical therapy report and put conversion disorder in there?
No, I'm saying at some point that I don't recall, in the medical record, her diagnosis must have changed from the physicians to include that, and that way it goes in my order because I work based off a physician order.
All right. Well, Maya's big complaints were in her legs, correct?
She complained about the function of her function of her legs, but it was pain. She complained of pain globally.
All right. But the big thing was you never got her out of the wheelchair, right?
We got out of the wheelchair quite a bit.
Not without considerable help.
With assistance.
Right. And we've got actually, I think, a video to demonstrate that. The 2703D. See, and I want you to then tell the jury whether this is just some assistance. Is that you?
Yes, sir.
Oh, really? If she has your medicine, which should be helping a little bit, I want to try to do the walkers that they're staying.
Is that you?
And just keep them there. Like you did with that.
Yes, sir, that's me.
Don't tell her that she got to see it, not you down. So I'm going to help you, but I want you to try to get your feet flat on the ground. And I'll hold you up to see your feet flat. Put your feet there. Turn longer. Better than yesterday. I thought that was awesome. Better than yesterday. I wish we had a seat. That was awesome.
What were you commenting there about her feet?
Yeah.
I did not hear, sir.
Okay. So that was you there, and this was Maya getting up on her feet, right?
Yes, sir.
And would you call that a little bit of help or a lot of help?
She requires a significant amount of help in order to transfer from bed to chair or from any surfaces.
Do you know Rachel DeYoung at Agility Fitness?
No, sir.
Okay, hold on one second, Mr. Anderson. Do you need help there?
It's new. You just
Sorry,
All right, do we have it off now?
I tried to keep it in here. It's off.
There we go.
Sorry.
Okay.
Totally no problem. It's happened to me the whole time. Okay, where were we? So Maya complains about her legs, and you were never able to get her to take any steps without considerable help. True?
Yes, sir, that's true.
And in fact, you had and documented confirmation of one of the reasons why, didn't you?
I need you to elaborate.
Sure. Well, Maya would exhibit from time to time spasms in her thighs, would she not?
I don't recall seeing spasms in her thighs. I don't think that's in my documentation anywhere.
Okay, can we pull up 1001-1911? Let's look at about the, I guess it would be 1, 2, 3, 4 lines down in the center. Highlight, please. This would seem to indicate that she had quad spasms noted throughout the session, would it not?
This indicates that she only had quad spasms when I passively moved her legs, which means she wasn't helping. I lifted them up to work on that range of motion and put them back down.
Well, you just said you didn't document spasms. Will you agree with me now that you documented what are quads? Quads are in your legs, right?
Quads are the muscles in the top of the front top of your leg. Yes,
Right.
sir.
Hold on a second. Do you want to just put it in the back room? I mean, it's not the 220 national alert. You can continue, Mr. Anderson.
So quad spasms are not something that someone, especially a 10-year-old girl, can create on their own. True?
I would say that's true.
You had objective signs there that in the biggest muscles in her legs, when you move them in certain manners, she had spasms, right?
In this instance, yes, that's true.
And throughout all of your therapy, this was the big thing with her. She did not think she could get up on her legs without, well, because of pain and or loss of, I guess, motive power or strength, right?
So spasms can be indicative of many things. Spasms can be a sign of weakness, which we know she had.
Well, I just ask you, sir, whether quad spasms are an involuntary action, right?
Yes.
Okay. And she complained of difficulty moving when she activated her quadratus muscles, right?
This is a passive movement, so she wasn't activating any of these muscles.
I understand that at this time, but that was her complaint, wasn't it? That when she was using these larger muscles in her legs, it was painful to her.
Yes, sir.
And here you take down that she has quad spasms in those muscles, right?
On this occasion, that's true, yes.
Why is it that, do you know who Rachel DeYoung is at Agility Fitness?
No, sir.
Okay, do you know Marissa Higgins over at TGH?
No, sir.
Well, Rachel DeYoung at Agility saw her right after you and had a different view of this. Would you agree with me that towards the end, Maya was not doing well at all?
No, I would disagree with that.
Okay. Well, let's take a look again at 1002-0188. And at the bottom there, you note the impressions, I guess as she's leaving. It's the last one. And does it say chronic pain there?
I believe this is the same treatment diagnosis that she had the entire time she was at the hospital.
Abnormality of gait and mobility, right?
Yes.
Abnormal posture, right?
Yes.
Weakness, right?
Mm-hmm. As I mentioned with the prosecutor or with the defense, like many things improved. We did not get her walking, which was my goal. Right, I wanted her to walk out of the hospital. She still had physical therapy goals to achieve, but some things did improve.
Well, insofar as all the diagnoses when she came in, physical diagnoses, your analysis, it was the same. Chronic pain, abnormality of gait mobility, abnormal posture, weakness, correct?
The treatment diagnosis was the same, yes. And we were still addressing all of those in all of our sessions.
Now, she also gave you visual confirmation that she was in pain, did she not?
Sometimes.
She would wince,
Sometimes.
and she'd tell you she was in pain.
Also sometimes.
And she would try on many different types of therapies, right?
She tried what she was agreeable to. Frequently on pretty much every session, I would ask her to do things, and she would refuse. And I wouldn't push her past that point of what she refused to do.
Because she would say she was in pain, right?
That's one of the considerations.
And by the end here, she had been some 2.5 months away from the pain medication that helped her, right?
I have no knowledge of that.
Okay. Well, Maya tried as hard as she could, did she not?
I believe she tried as hard as she could, but she often refused and refused to accept any education on physical therapy treatment, and she wouldn't push herself past a point that she was comfortable with.
Do you think that's because she'd already been through all of this before at Tampa General Hospital?
I can't say what she was thinking.
Could it possibly be because this 10-year-old little girl had already been through all of these exercises and had people tell her, no, you can do it, when she knew she couldn't physically, at least without overpowering pain? Is that possible?
Objection calls for speculation.
Sustained.
Let me show you a video of Maya at TGH, if we have it there. I'll represent to you, this is at TGH in the summer of 2015.
She's not ready. There she goes. She's getting up. There she goes. You help her through? Here we go. Okay, come on, left.
You don't believe me? Well, too bad. Let's go.
Come on, left. There it is. That was great, Maya. Come on, good. Love it. Yeah. Very good. Very good. Maya. Very.
Giddy up, Percy.
Giddy up, Percy.
Giddy up. You don't believe me?
I do. Come on. Good. Woo. Good. That's it. Maya, that's awesome. Very good. Okay. You almost my mommy. Almost there. I was going to tilt her that way. Yeah. There we go. Here we go. Whew. You both are getting a workout, aren't you?
Okay.
Yes.
Would you agree with me that that little girl's trying?
Yes, sir, I would.
What are those boots she has on?
Those are called AFOs, ankle foot orthoses.
And why are they put on?
Those are put on to help her foot stay in a flexed position in order to help prevent foot drag or trips and falls.
Well, the jury's seen multiple photographs of Maya Kowalski's feet in that position. Are you still contending that she did not have the dystonia in her feet through the entire time she was there?
So my experience with dystonia is them being in a down position. Just being in a down, relaxed position is not dystonia. That's what we call either foot drop or a muscle weakness in the muscle that's in the front of our leg. Dystonia is something very different, having to do with the muscle in the the neuro relationship, causing the foot to maintain in a fixed position.
So Marissa Higgins at TGH and those doctors there, they were not trying to treat dystonia with those boots.
Objection, having witness comment on the opinion of another.
That's an uncommon.
Sustained.
Well, why is it that every other therapist has testified saw Maya with dystonia both before and after her Johns Hopkins treatment, and you found there is none?
Same objection also calls for speculation and lack of foundation.
Sustained.
How could it be that in October, from June, July, August, September, and into October, those physical therapists found that she did have conversion? There's photographs of conversion. And then after Johns Hopkins in January, through the next 4 months, there are photographs and physical therapists that have testified that she had this dystonia, and yet she did not have it during the period that you had her.
Same triad of objections, Your Honor.
Sustained.
Is it more likely that you're describing dystonia but trying to describe it as it's not dystonia?
No, sir. My experience with Maya was her feet were always in a down, relaxed position. And if they were to touch the ground or move on the ground, her ankles were flexible. My experience with dystonia is once your feet are kind of locked in that inward or down or outward position, very little can be done to help move them. Even maximal force to kind of move it out of that position can be very difficult. Whereas I always observed her with her feet in a down, relaxed position.
So you're saying you think Maya was trying to keep her feet in that position?
No, sir, I don't.
All right.
That's just the relaxed, resting position of all of us.
In point of fact, Maya, you were looking, I guess, for signs of paralysis.
I personally I don't recall looking for specific signs of paralysis. My job as a physical therapist is to assess the patient and to find those limitations, whether it's weakness, decreased range of motion, movement deficits, and come up with a treatment plan to treat those deficits, not to make a medical diagnosis.
Do you contend that CRPS, one of the symptoms is paralysis?
With my experience with CRPS, paralysis is not a symptom.
And Maya never contended she couldn't move her extremities, did she?
When I would ask her to do something like a leg kick, she would say that she can't.
Because she was in pain that day, right?
Yes, that was part of it, and part of it is she just said she can't.
And you disbelieved her, though, on many occasions. True?
I never disbelieve any of my patients when they say they're in pain. I take that at face value.
All right. So she was then in pain. Sorry, Judge. Make sure I get all these. And is it true that by the time she left, she had to slump over in her wheelchair?
Not by the physical therapy documentation.
Well, let's look at, if we can, 1001-1870. And I'll represent to you that this is your note from January 4th, 2017. You recognize it?
I'll need to review it shortly, but yes, it's my note.
Mm-hmm. And in the third sentence, does it say that the patient slumped over in her wheelchair?
This was the very beginning of the session where we sat on the side of the bed, and while we were getting prepared to get into the wheelchair, she had slumped to the side.
I just asked you, it said she was slumped to the side in a wheelchair.
No, sir. It says she slumped to the side on her bed.
Okay.
Anything further, Mr. Hughes?
Yes, a few follow-ups. Mr. Cecil, do you remember Mr. Anderson asking you some questions about whether or not Maya Kowalski improved over the course of her physical therapy treatments with you?
Yes, sir.
Can you please describe to the jury the type of improvements that you observed over the course of the approximately 3 months that Maya Kowalski was in the physical therapy service at All Children's Hospital?
Yeah, so we, like I said earlier, there's 3 main areas we saw significant improvement. One was that sitting balance, ability to sit independently in a wheelchair, participating in activities. We saw it in the video of her playing the piano. That was consistent throughout the time she was with us, especially near the end. The second was her posture. She improved from this slumped, assisted posture to an upright posture with no assistance, no visual or verbal complaints of pain during activity in that sitting position, oftentimes smiling, having fun playing games, or talking about things that she enjoyed. The last one is her activity tolerance. So going from being able to do 1 to 2 minutes of sitting with assistance in severe pain to doing enjoyable activities, including in the documentation we oftentimes got from her wheelchair down to a play mat. And she laid on her stomach, propped on her elbows with her back extended, reaching and playing with games, or different various positions that she would be agreeable to, that we would try. So all 3 of those areas we improved. I wish that we could have progressed her more in the standing and walking. Like I said, that was the big goal, but we just didn't get there.
Mr. Cecil, do you recall being asked by Mr. Anderson about some documentation you had of quadricep spasm, I believe?
Yes, sir.
And that was during passive motion, I think you said?
That's correct. That's what the documentation said.
Now, I think you also said that spasm can be a sign of weakness. Did I hear that correctly?
Yes.
Objection leading.
Let's hear the next question.
Sure. In your experience as a doctor of physical therapy, can the fact that a patient has been in a wheelchair since, in this case, July 4th of 2015, be the type of weakness that could lead to spasm?
Objection leading, yes or no answer.
Overruled, you can answer that.
Yes. Knowing her history and that she hadn't walked for such a long period of time, that by itself, when you move that leg or when she tries to move that leg, it can cause muscle spasms that will then cause pain. I equate it similar to a patient after a big knee surgery, like an ACL surgery or something like that. You start moving that leg, it's painful because we're moving it, but also you can see these muscle spasms because we're moving that muscle that hasn't been moved.
I'd like to draw your attention to your what I believe to be your final physical therapy note of July 4th of 2017. It's in evidence at 1001, 1870.
July 4th?
It is, I'm sorry, did I say it's January 4th of 2017. This is at Johns Hopkins All Children's Hospital. January 4, 2017. Do you recall I attempted to ask you about this earlier? And I completely butchered the question. Do you remember that?
Yes, sir.
Yeah, okay. I'd like to draw your attention to under assessment and goals. There's a line that says she displays the functional strength, and we'll highlight it for you. I'm going to read it out loud. But if you could please highlight where it says she displays the functional strength to complete tasks. And that is the highlighted section there. So take a moment to please review that highlighted section and explain to the jury that after 90 days in your service, what does this statement mean at the end of your therapy with Maya?
So functional strength is the strength enough to perform activities. Do you have the strength enough to sit to reach, to do those things. Throughout all of these notes, it's noted that she has strength to reach, to hold herself up, even when stimuli is presented to her, reaching for a game. In one of my notes, something fell on the ground. She bent all the way forward, grabbed it from the ground, and returned to a sitting position independently with zero assist. So she has the functional strength in her core and her arms to do all of these things. And when she's distracted, she does them. She reaches, she leans, she saw in the video, she even moves her legs a little bit to reposition herself. But then when asked to perform specific activities, the things that we're trying to improve, she actively presents with impaired function, meaning those things we just saw her doing with that functional strength, now that the attention has been brought to it, she's no longer doing those things. And that's a consistent inconsistency that we found throughout her time with us.
Mr. Cecil, thank you for your time. I don't have any more questions for you.
I just have one, because there is, that wasn't in fact the last one of the physical therapy reports, was it? Did you have one more on January 11th, 2017?
I don't recall.
Okay, let's take a look. It's in evidence, 1002-0185. Now, to take a look here and tell me, would you agree with me that since Maya's admission, she was doing progressively decreased activities independently, including what? Did that include propelling her wheelchair? Did it include lower
I don't see my
extremity
name on.
exercise?
I don't see my name on this page anywhere. I just want to make sure this is my documentation.
Sure.
I don't want to speak on something that's not mine.
Yeah, the previous page I think shows it. But,
Okay, thank you.
okay, so are you noting here, or I guess the PT department, I think it's you, noting since admission she'd been performing progressively decreased activities independently, including propelling her wheelchair, lower extremity exercise, and participation in physical therapy tasks?
I think my documentation shows that I never documented seeing her propel her wheelchair. That might be in reference to someone else's documentation, but her participation in physical therapy tasks definitely decreased, as I mentioned before. And her lower extremity exercise decreased because she was refusing to attempt a lot of passive movement, me doing it, any active movement, or even attempts at standing, like you said.
All I was asking you is whether you put down here on her very last visit that her performance was progressively decreasing. And that's true. That's what you did, isn't it?
In these three areas, it might have decreased, but in those other areas, there was a significant increase.
And anything else, Mr. Hughes? Members of the jury. Members of the jury, I'm going to send you back. Now, I will tell you after I review these questions with the lawyers, we will then take our break. So it's probably going to be 20 minutes before we can get back to you, okay? Do not discuss this case.
Jurors enter.
out of our presence. Doctor, we're going to go through these questions outside your
Judge, I misspoke, just for the judge, for the court, the Malik Deb is 58 minutes and 55 seconds.
So you owe me 3 minutes and 5 seconds.
Just let you know, because I don't know how long the question is going to take.
Well, and this is the one that was 2 hours and something?
It was.
Yeah. That's progress.
I'm very pleased about this.
There we go. Anything before we bring in the jury?
We have the dates of the videos, Your Honor, if you want those.
What are those, and you want me to just announce them?
I'm sorry.
What, not a TGH video? Are you talking about the info too?
We have the date of the TGH video. It's August 14th, 2015. The EEG video when he's transferring her into the wheelchair is October 20th, 2016. And the piano video in the lobby is January 3rd, 2017.
Okay. And you want me to just announce those dates to the jury?
Yep, no objection. Your Honor.
Okay, let's bring in the jury. Let's bring in Dr. Cecil. Please be seated. Members of the jury, I want to confirm while you're away, you did not discuss this case amongst yourselves, you did no investigation, and you received no information. Is that all correct? Correct. And no media, correct? Correct. No one approached you, correct? Correct. In the questions, there was a request for the dates of the various videos that were shown to this witness. And I'm just going to tell you the dates of those videos. The Tampa General Hospital video was August 14th, 2015. The EEG video was the October 20th, 2016. The piano in the lobby was January 3rd, 2017. Members of the jury, I went over these questions with the lawyers outside of Dr. Cecil's presence, so this will be the first time he's heard these. In the video, it seems odd that you would try to make Maya stand up without some equipment or warm-up. There was also a question about the date of this video, so any comment on that statement?
Sure. So I think that video was one of the very first times I met her. So what's not shown in that video is probably what we did in bed, if we did any activity in bed, trying to assess where she was at that day. I don't know for sure. I can't recall exactly, but once we sat edge of bed, as we talked about, she wasn't kicking her legs, she wasn't moving her ankles. But what we did see in the video is once we were sitting edge of bed, she was interacting with us. She was pleasant. And when we were ready to complete that transfer, we call it a stand pivot transfer, going from one surface to another via a pivot. She leaned forward and leaned into it and participated with us. Yes, she needed a lot of assistance, but she was actively participating in that transfer. So what we did before that moment, I can't recall exactly, but doing that transfer, she was actively participating in that and willing to do so.
Does it not seem reasonable Maya would be moving and sitting better during the piano video, given it was January 3rd, 2017, and she would have had numerous physical therapy sessions?
Yes, exactly. I think that's exactly the point, is that we've been working with her that entire time, working on sitting activities, so it's entirely reasonable that her sitting is better, because that's a lot of what we worked on. We were working on core strength, core stability, sitting balance, dynamic sitting balance. So I think it's entirely reasonable that by January that it improves, because that is the majority of what we were working on.
Did you think that her being Maya's lack of participation was due to her growing depression with being away from home?
I'm not a psychologist, so I don't know that I can comment on depression or anything of that sort. I think that's outside of my scope of practice. So,
is distraction a typical tool to use in PT with children?
Yes, I think it's one of the most common tools that we use. Sometimes we see kids of all ages, and when we're in the hospital, they're focused on a lot of the things other than what we want or need them to do. So for Maya, we use distraction to get her focus off of the pain and onto an activity to improve her strength and function. For another patient, say like a 3-year-old who has cancer, we might use play as a distraction. Instead of, we're not going to engage in conversation with a 3-year-old, but we're going to present toys that they enjoy or an activity that they enjoy at home in order to distract them from all of the lines and tubes and everything else going around them in the hospital, to focus on the task to improve their function or whatever their goals are.
Before caring for Maya, had you had any formal training provided by Johns Hopkins on CRPS?
Yes, I had. So when I was a student, I had a clinical internship at Johns Hopkins, all children's in their outpatient sports clinic. And during that time, we had seen several CRPS patients. So at that time, I was under the clinical supervision of a licensed therapist, and we had frequent discussions about what proper treatment is for patients with that condition. Also, when I became licensed and got hired as an employee at Johns Hopkins, when you're a new employee, you have clinical mentors who you can throw ideas off of, treatment ideas, things like that. As was brought up, there was another PT who was also treating Maya at the same time, so we would frequently go back and forth with treatment ideas or techniques or things that we could try during various sessions. So there was a significant support in training, I feel, prior to seeing Maya.
Before caring for Maya, how many CRPS patients had you cared for?
So prior to seeing Maya, I finished that 4-year degree in physical therapy school where we talk about chronic pain. We talk about CRPS and proper treatment. I had seen 2 or 3 maybe during my clinical internship, maybe 4. And then while I was licensed before Maya, between my outpatient experience and inpatient experience, it was probably around 5.
Is it more common to have a spasm with passive movement on a limb that has not been moved in a long time?
Can you repeat that one more time? Sorry.
Is it more common to have a spasm with passive movement on a limb that has not been moved in a long time?
I don't know that it's more common. Spasms can be caused by different reasons. So passive range of motion is, like I said, the patient doing no active movement, right? They're not squeezing their muscle. They're not activating any of their muscle fibers. It's simply the therapist lifting their leg, working on range of motion, usually of a joint. So like I said before, if you're weak in that leg or that muscle's not used to extending and flexing with what we're doing, it can cause a spasm. But also, with active range of motion, those can cause spasms too. And there are other reasons that spasms cause with no motion. My work with Maya, from what I recall and from the documentation, that's the only spasm I noted. And the 20 hours I spent with her, 21 sessions, that was the only time I documented on a spasm. And I don't recall any other active or passive spasms during my time with her.
Other physical therapists that worked with Maya indicated in testimony that CRPS patients find cross-leg position, crisscross applesauce, the most comfortable for that condition. Is that not your knowledge with regard to that leg position?
So my experience with CRPS over the last 9 years is that it's highly variable. CRPS can affect any limb of the body, in any joint of the body. So, and that allodynia, that hypersensitivity to touch, can be in various areas. So it's really highly dependent on where the patient is having their pain, what it feels like for them, and then what their comfort positions are. So I don't know that I could say in general that crisscross is a overall general comfort position for patients with CRPS. If I have a patient with CRPS of their elbow, they're not going to have a problem getting into crisscross. But if I have another patient who has CRPS of their knee, or in their knee, crisscross may be very difficult, or it might be that comfort position. It's highly variable how these patients present. So I wouldn't say, I can say in general that that's a comfort position in general for CRPS patients.
I see in your note from December 1st, 2016, and then also documented in January, that you documented, quote, transfers to and from the couch with max assist, end quote. Can you please define max assist to the jury?
Sure. So in therapy, we use different terms to describe how much assist a patient needs. And it's a scale. So max assist would mean the therapist is providing 75% and the patient is providing 25% of the effort, or of the effort to complete that task. So 75% total assist would be 100% for the therapist. Mod assist, as I said earlier, is 50-50. Min assist would be 75% for the patient and 25% for the therapist. And then we use words like contact guard assist, which is mean just like holding their hand or holding their back for support, or standby assist, which is being close and monitoring, but seeing them do it by themselves.
Did you have any interactions with Kathy Beatty regarding Maya's care?
I remember working with Kathy Beatty. I don't remember having any conversations specifically with her about Maya.
So you wouldn't know how often those interactions were?
No idea.
Did you attend interdisciplinary rounds on Maya?
I remember having many communications with various providers about Maya and her case and how she's presenting, and kind of giving my input. I don't recall attending any specific interdisciplinary rounds where everyone got together.
So if you don't recall, then you wouldn't know who was present.
Correct.
Were you aware if upper or senior management was aware of Maya being in your hospital?
I have no reference to know whether they did or didn't.
We have heard testimony Maya was a fall risk. Is it a policy at the hospital to use a gait belt when transferring children with a fall risk at the hospital?
It is. There are various thoughts on gait belts, whether they're helpful or not. I believe after this video, we did have gait belt on her frequently. I think during the video you saw, I didn't have a gait belt because that was one of my first times seeing her, and I was assessing what she was able to do. Still providing the proper assistance to make sure she didn't fall. She was safe, monitored. But afterwards, I do believe we had a gait belt on her when we brought her down to the therapy gym and things like that.
The exhibit 1002-0188 that read conversion disorder as a treatment diagnosis had an admitted date of January 6, 2017. do you know if this diagnosis was listed on the previous admitted date, October 7th, 2016, when you first started therapy?
I don't know off the top of my head. The way those medical diagnoses are viewed from a physical therapy perspective is that doctors make those medical diagnoses, and they end up in our chart based on what the physicians consult us for. We're a consulting service, so in order for us to come see a patient, the physician has to consult us to come and work with them. My treatment diagnoses under that are the physical therapy treatment diagnoses, the things that we're trying to improve. I think that answers the question.
Next question. Back in 2015, when you were employed by Johns Hopkins All Children's Hospital, you were very book smart, but you were new to the position. Now, 8 years later, I believe you testified what therapies you use for CRPS today are the same that was used in treatment for Maya back then. In 8 years since Maya, you are saying there has been no improvements in the therapies used for CRPS patients, and that's a question.
So the conservative physical therapy treatments that we use for all CRPS patients are research-based. They're contained, and research is shown within what's called the clinical practice guideline, which is held by the APTA, which is the American Physical Therapy Association, which is the national organization over physical therapy. So they have it's called a clinical practice guideline. So it has the collection of the research that shows that physical therapy treatment, various physical therapy treatments are effective and beneficial for the treatment of complex regional pain syndrome. Every so often, no new research comes out. To my knowledge, the graded exercise that I've talked about all day today, that, based on how the patient is doing, pushing them within their limits to do as much as they can, grading them up to do more, grading down if it's a day where they're having more pain or more complaints. That is the standard for physical therapy treatment. We have options within there like therapeutic exercise, working on ADLs, things like neuromuscular rehab, which is kind of making the connection between the nervous system and the body in order to improve the function. But at the end of the day, the big goal of physical therapy, what you're trained to do in school and in your internships and in your training on the job, is to find those impairments, find those difficulties, the range of motion, the strength, the walking, and then develop a treatment plan to improve those things. And that's exactly what we did with Maya. Our treatment plan, the treatment plan I wanted to perform with her didn't go exactly as we wanted, right? As I said before, she wasn't walking when she left, but we did things every single session that was inside that clinical practice guideline in order to help her improve in her function.
Dr. Cecil, you stated at first Maya was 5 or 6 times a week for therapy. Is that correct?
Yes.
As time went on, it was lessened because Maya refused or couldn't do it. Refresh my memory. Was it refused or could not?
It's a combination of both. She, at the beginning, if you're reading through the notes, the first several times I saw her, we were attempting to stand. We were, supported standing with assistance in order to start building strength in our legs and to tolerate standing more. The goal of those sessions is to work through the pain in order to become more functional. Oftentimes what we see in chronic pain patients, CRPS and other chronic pain, is that function improves before pain improves. And that was our goal, is to improve her function. That's the physical therapy goal, is improve her function. So as we kept going, her function was improving in some ways, but in the areas that we wanted to see improvement, the standing, walking, participating in those things, she was flat out refusing, which we were never going to push her past and into something that she was refusing to do. We were never going to make her do something that she said she couldn't do. When she was agreeable, when she would take in any education and participate in things that we know would be beneficial, then we would do those things together. But at the point where we decreased her from that 6 times a week to 3 times a week, we had gotten to the point where it had been several sessions where we had plateaued and not made any progress. We had reached those goals that she left with. So that's why we decreased her, with that knowledge of if she can start doing more, if during those 3 times a week that we're still seeing her, she can start doing more, she can show us that, hey, look, I can move my legs a little bit, I can tolerate it, I want to try, I'm not going to refuse, then we would have immediately moved her back up to a higher frequency and seen her more often.
Could this, quote, could not, would not, end quote, been a result in Maya's CRPS affecting her physical or mental abilities and therefore her performance?
Do you mind repeating that one more time?
Could this, could not, would not, been a result in Maya's CRPS affecting her physical or mental abilities and therefore her performance?
Certainly her medical condition affects how she's going to participate, how she's feeling, how she interprets her pain affects how she participates in therapy, 100%. Her mental capacity, that's outside my scope. I'm not going to comment on that. But our job as a physical therapist, as I mentioned, is we're going to grade what activity we do. Like I said, grade up, grade down based on how she's feeling and her feedback on certain activities. So if she, I think there was a good example in there of sitting in her wheelchair, she was doing well, we were doing things, and I wanted her to transition to a chair that had no arms. I had seen her sitting in her wheelchair without using the arms. So I was like, oh, let's transition, maybe a stand pivot, maybe a scoot into this chair that has no arms, and then continue doing what we're doing. But she would say she couldn't do it. She refused. I would try to educate her on why that's important and how, hey, it's the same. It's just another chair without arms that you're not using anyways. But I didn't make her do it. If she refused and said she couldn't, or she was fearful of falling, even with me there guarding her and protecting her, we didn't go there. We didn't do that.
Mr. Hughes, any follow-up?
No, thank you.
Mr. Anderson.
Testified that the only time you had noted muscle spasms. Can we look at 1001, 1914? Top of the page. You see right there in the top?
Can you go to the previous page so we can see the whole sentence?
Page 5. He wants to see the page prior. Is that you?
Yes, sir.
Let's look at 1947. Second from the bottom, well, third line from the bottom. 1947. It's actually second line, yeah, from the bottom. Yep. Across there, there you go. Okay, let's see. Is that you?
Yes, sir.
3 times that you noted muscle spasms in her legs. Is that right?
Yes, it is.
And when you started out, she was receiving some pain meds, but then you stopped those as time went on, right?
I don't have anything to do with musts or medications. I don't prescribe. I don't give them out. It has nothing to do with medication.
Mr. Hughes, anything?
No.
Members of the jury, any follow-up? Okay, may this witness be excused?
Yes, Your Honor.
Yes.
And released from subpoenas?
Yes, sir.
Thank you, sir. Thank you. Okay, members of the jury, we have, I understand, a deposition that is...
Can we approach?
Sure. Is we have about 1 hour video. This is the video that we started the other day that was going to be more than 2 hours, but we've got it down to just under 1 hour. So,
58 minutes, 55 seconds.
like I said, just under an hour. So I say we just do it right now, and you'll get out of here about 5:15. Do you want the lights remain, or do you want them dimmed some? It looks like everyone's, am I saying everyone wants them up or down? All but one want them up. I'm sorry. Let's, Ms. Krells, if you could tell us who we're calling again.
Yes, it is the deposition of Dr. Farhan Malik, taken on November 12th, 2019.
Yes.
Please state your name for the record.
Farhan Malik.
Oh, no.
And you are a physician in practice employed by Johns Hopkins All Children's Hospital?
Yes.
And where'd you go to college?
New York Institute of Technology.
Year you graduated?
2005. 2005. Yeah.
Medical school?
New York College of Osteopathic Medicine.
And where's that located?
It's also located with New York Institute of Technology. They're both in Long Island.
And what year did you graduate your 4 years there?
09.
For the benefit of the jury, can you give them a very brief description of the differences, if any, between an MD and a doctor of osteopathic medicine?
Sure. The degree is actually called a DO.
Yeah.
It essentially is very similar to MD schooling. You just take additional courses in osteopathic manipulation, which I liken it to chiropractic. And so you have the option of practicing that when you graduate versus just practicing as a regular doctor.
Again, I don't know how accurate this is because I'm just reading off the internet, but osteos tend to be literally more hands-on with the patient. I mean, there's more manipulation and testing, feeling, touching, that kind of thing in diagnosing?
Yeah, you take classes in the manipulation aspect of it, and if you choose to practice that, once you're done, and incorporate that into your practice, if you're in a field where you can, such as internal medicine or general practice, becomes a little different when you become more and more specialized.
The area that you chose to go into was critical care with a focus on cardiac, is that right?
Yes, cardiac intensive care.
All right. And where did you do your residency?
Newark Beth Israel Hospital, so it's the Children's Hospital of New Jersey.
And what year did you, what years were those?
So that would be 09 to 2012.
And after residency, what did you do?
I did my fellowship in pediatric critical care at the University of Texas in Houston.
All right. And what year were you licensed to practice medicine in the state of Florida?
2015.
So at the time you saw Maya Kowalski and her October 7th admission, you had been a licensed physician in Florida for 15 months? Let's see, May, so 12, May, June, July, August, September. So about 16, 17 months?
Yes, I believe, approximately.
You were a fairly young doctor, relatively speaking, experience-wise.
Yes.
And were you licensed in any other states?
New Jersey.
And what year were you licensed in New Jersey?
That would be at the start of my, or the conclusion of my residency, so that would be 2012.
So after your fellowship at UT Houston, where did you go?
Johns Hopkins Old Children.
And what was your position?
Pediatric critical care physician.
And what does a pediatric critical care physician do?
All things involving intensive care. So if a child gets admitted to the ICU for any number of reasons, trauma, sepsis, after surgeries.
Would it be fair to state then that as of October of 2016, you were not an expert in complex regional pain syndrome / also known as RSD?
Yes, that's very fair.
Would it be fair to say that as of October of 2016, you were not an expert in medical child abuse?
Yes.
You were not an expert in factitious disorder by proxy?
Yes.
You were not an expert in a conversion disorder?
You're listing a lot of psychiatric disorders that, no, I am not an expert in because I'm not a pediatric psychiatrist. So.
Okay. And then Munchausen by proxy, same answer?
Yes.
Not an expert in that either. All right. When was the first time you met Dr. Sally Smith, if you recall?
I don't believe I've actually ever met her.
Have you ever spoken with her on the phone?
I can't recall exactly, but I might have spoken with her regarding this case.
Did you know of her, even if you didn't speak to
Yes.
her or see her?
Yes.
And what did you know of her as of, say, the period before
Sure.
October?
That she was our go-to person to speak to if you had concerns of child abuse.
On any of Maya's prior admissions or visits to the ER at ACH, had you ever run into either her or her family?
No.
So the first time you ever met any of them would have been on that October 7th visit?
Correct.
And do you know Dr. and it's Tepes Sanchez, but I think everybody just calls her Dr. Tepes. Is that right?
Correct.
Okay. Did you know Dr. Tepes before this admission?
Yes, we're colleagues.
And how long had you worked together?
A couple of months.
There has to be some structure in your mind about, do I make a call, don't I make a call, or do I recommend a call or not recommend a call?
Part of being a pediatrician, if you suspect child abuse, by law, you're obligated to report it.
So what are some of the things that create a suspicion to you?
Position. Why don't we just let you go home?
Okay, okay.
Do not discuss this case amongst yourselves. Do not do the investigation and receive no information. Now, tomorrow we're going to start 15 minutes later than normal. So I need the jury to be ready to go at 9:15 as opposed to 9. You get 15 more minutes to sleep in.
Oh, very nice.
All rise. Jurors exiting.
Have a good night.
Thank you. Thank you.
Thank you all. Please be seated. So we'll try again with this one after we.
Judge,
look
I'm
at
not
it.
sure. My apologies to the court. I don't know why where we're at with that, but I will look at what's going on and confirm.
Let's talk about what we need to do with the remainder of our time. You were saying something about Dr. Hannah's deposition, right?
Oh, yeah, Judge,
Sidebar.
again, I don't know if this was a miscue. Again, everybody's trying to do, 5 different things. My understanding is we only designated pages in the 2020 deposition that we're going to play. I think the other side maybe was looking at old designations and spent a lot of time looking at the 2022 or 23 dep. But my question to the other side is, time you'll never get back, I get that. We are only playing the 2020 dep. Did the other side also want to play designations from the 2023 dep? If so, we'll look at those.
Yes, we would, because we didn't get a substantive cross until the later deposition.
Okay, so you intended to do those designations?
Yes.
Okay, that's what I needed to confirm, so we would look at those for objections.
And I'd
Okay.
be happy to look at a clip report once it's done to make
Yes,
sure.
I'll be happy to send that to you.
And so do I have, I know I've gotten 2 Dr. Hannah depositions, but do I have
There
the
were only 2.
objections for?
No.
I only have one side's objections?
We haven't seen their, we haven't had a chance to see their counters, Judge. They just got filed, so we have not looked at their counters for objections yet.
And what time do you think you'll get a chance to do that?
One of us will make it a priority as soon as we get to the hotel, Judge, to look at those if we're leaving early. We don't do that as soon as we get back, to look at their counters for objections.
And then why don't you use the email that over the weekend?
Yes.
And I'll be at a place with no electronic service capabilities until after 10 p.m. tonight. So I won't be able to get you anything until close to 10 or around 10 tonight. And then depending on when I get your designations and the volume of it, that might impact the time I'll return it.
It's a 325-page deposition, volume 1. So
We didn't
I
designate
don't.
that much.
Forewarning.
I just, on that point, since I know your shot clock is where it is, we only designated like 15, 20 minutes. Did you designate hours of this?
We designated a fair amount. I can't quantify it.
I mean, okay, just to.
They have been better this week on usage of time.
Okay. Your Honor, just to piggyback on the last question, we do intend to publish some of the emails that are admitted in evidence, and I hear there's an objection from the plaintiff about just publishing them. We're looking for some guidance. Would they like us to recall our expert, Dr. Crane, or one of our experts to publish them through, just so that way we have the right personnel if they're just objecting to us publishing them?
I mean, their admissions.
Their admissions by a party. I don't know that I need to do it through a witness. I obviously don't have the witness who wrote them to publish them. So if we're running out of trial days, I just didn't want to get in a situation where the plaintiff's going to object to the publishing. If they require them to do it through experts, then I'm happy to recall experts.
We'd like some consistency here. We've heard repeatedly throughout this trial objections to us publishing documents unless they're through certain witnesses. We've heard repeated objections. They're out of context. So if we're free to publish party admissions out of context, I'd like to consider it with Mr. Anderson and get back to them in the morning.
I'm trying to remember, because I know the defense has raised that identical objection, and I'm trying to remember how I handled it.
Judge, I know that there was at least one thing that was published to the jury, because I was going, there's no context, and you said it's in evidence, and then they published it. So I don't recall what it was. I don't know if it was a policy or what exactly that was, to be honest.
Was that the one right after a video dep?
I don't,
Because
honestly.
I remember doing a couple right after a video deposition, and I
think it
don't
was-
remember if those were exhibits that were referenced in that deposition or if they just were freestanding, and I just don't remember.
I think they were just freestanding, Judge, because I remember losing the objection, but in all honesty, I couldn't tell you what it was at this time.
You won't be surprised we have different memories of that.
Well, again, just because I know that we have to give them 24 hours notice for what witnesses are coming, assuming they don't want us to be calling witnesses into Wednesday, we would just like to know who they would require. I just don't want to have Dr. Crane come back by Zoom, put them on in front of him. If they don't want us to just publish them without a witness, I'm happy to call a witness, but there's obviously only so many witnesses I could do in contact.
Are you talking about doing all of the ones I admitted yesterday?
There's so many of them, no. My plan today would have just been to publish 2 and maybe 3. It would have taken 10 minutes of our case to do so.
Is it 2 and maybe 3 and that's it, or is it 2 and maybe 3 intervals going forward?
Probably 2 to maybe 3 intervals going forward. We only have 4 trial days left, so that would be 10 minutes of publishing per day.
I'd like to discuss it with Mr. Anderson and see what our position is going to be.
That's fine, but let's come to a final resolution in the morning on it. I mean, obviously it's preferable to do it with a witness, but if they are in evidence, ultimately they're in evidence.
Understood.
What's next? Are there other exhibits that we're
do you
needing to
wanna-
go through?
Okay.
I mean, since we've found ourselves with a few minutes, might as well
Sorry,
try
Judge, I
to
was packing up. Let me.
use the time efficiently. And since there's not a further witness today, the shot clock stands today. Plaintiffs consumed 1 hour, 20 minutes, and that places you at 54 hours. The defense consumed 2 hours, 30 minutes. That places you at 33 hours. 24 plus 9 is 33, yeah. 33 hours.
You ready, Judge?
Yes, ma'am.
So I would like to, and I appreciate this is another email, but it's a different time frame than what's in. It's 32320141, and I think we have an edited version that just contains Beata Kowalski's Facebook post. But it's October 12th, 2015. I had a chance to look at the emails that the court has allowed in. This is the only email that addresses this. This is her description of the ketamine treatment that she was undergoing with Dr. Kirkpatrick. 32320141, and I believe you edited it so that it only had, I have a hard copy here. Well, that's too edited. I can't do that.
That's 3231, not 3232.
Oh, yeah, I need 3232. There we go. So, Judge, this is dated October 12th, 2015, and if you look at the description, it is her description
Can you make it a little bit bigger? Thank you.
of the ketamine treatment that she's undergoing with Dr. Kirkpatrick, describes how it was, describes the hallucinations that Maya experienced. And it goes on to the next page.
Well, I need to finish.
I have a hard copy, Nick, if you can pick it.
Next page, please.
And this was edited to end at, should be edited after the top, after the top paragraph. We would delete the rest, which I thought had been done. So this is the only description of the ketamine treatment with Dr. Kirkpatrick. The other emails started after this, Your Honor.
Whenever you're ready, Mr. Whitney.
We object, Your Honor, based on the court's previous statements about the number of emails that have already been let in. We object on 403. We object on hearsay. And we also reiterate that this goes to none of the pending claims. I think the court's still waiting on a response on Fabre. And as the court pointed out the other day, however Maya presented at the hospital on October 7, 2016, you don't go back and recreate the accident to figure out what happened a year prior. So there's no relevance to this email from our perspective, or Facebook post.
Judge, this goes to the concerns that the doctors had with regard to the amount of ketamine. It also goes to dispelling the presentation that's been given to this jury by Dr. Kirkpatrick, that this was very safe, there were no issues, that it was not a problem. Clearly there was a lot of issues during it, as described by Mrs. Kowalski, who was there.
Then the last reference to the GoFundMe.
Well, that's we can take that out, Judge. I mean,
The exhibit, with the exception of the GoFundMe, I'm fine with.
okay. So we'll end it. We'll take out 4 more updates in the remaining sentence.
Let's make sure the clerk gets a printout of the updated exhibit.
Okay.
What's next?
Let me just make a mark to it on my screen. That was and 3309. These are Dr. Patrick's billing records.
3309.
3209. I'm sorry, 3309. It's on the, yeah.
How many pages are we looking at?
8.
Just go ahead and scroll next page. Next page. What is this? We're on page 3. What is this?
Page 3.
What is page 3?
I'm sorry?
I'm asking Ms. Quarles, what is page 3?
I'm sorry, what is page 3?
Yes.
It looks like the health insurance claim form, Judge, but I'm not sure why.
Next page. Next page. Next page. Next. Next page. Next page.
That's last page.
Can you go to the first page, if you don't mind, Mark? And the next page, too. look, we're going to withdraw it. I don't think it makes sense in sequence.
Okay. What's next?
Can we have 1 second, Judge?
No. Okay. That's fine.
Judge, just for the record, can we go to 3023? So I'm not sure if the court's rule on these. I understand, this is Arnold Palmer hospital records, and I understand that Your Honor has not allowed the testimony of Dr. Alexander. We went over that yesterday, I believe it was. These are the actual records, so I wasn't sure if the plaintiffs are objecting to all of these records going in or just the records with the statement that mother states, etc. Does Your Honor recall the issue? Am I being clear?
Give you a little bit more.
Sure. We wanted to play the deposition of Dr. Alexander, who had the history from the mother that she states that she was injecting ketamine into her report. Your Honor, it did not allow us to present that testimony. These are the records from that visit, which obviously include more than just that one statement. So we wanted to put the records in, the records in. Understanding that that statement's in there, I didn't know if the court was going to require us to redact that, or if none of the records were coming in, and I wasn't sure of the plaintiff's position.
We'd be fine with the redactions, but it'd be a 403 issue without the redactions. I think we've discussed this at length.
Well, what we discussed was the deposition. I don't think I discussed the
Okay.
records, but the concept of IV ketamine at home needs to come out of these records if they exist in there.
They do, Judge. That's what he was testifying from, and he was testifying from the history he took that is in the records where it says mom states that she is giving, I don't remember the exact quote, but ketamine at home.
I still maintain there's a significant 403 issue with the concept of the ketamine via IV at home issue that has been discussed for years. So that concept, if it is out of the medical records redacted, then I don't
Okay,
think
so
that
we
would have a
will
problem.
look at the record and, did you have something?
I was just going to say, there's actually two doctors in these records that say more or less the same thing, so we just need to make sure we
Yeah,
get both
so
sets redacted.
we
for
will
both doctors.
redact based on the court's rulings and then show it to counsel and go from there.
Thank you.
And next.
Okay. Um, 3080? 3080.
Just exhibit 38?
I was going to ask her, it's a video.
Yeah. Aren't they 4 digits?
I'm sorry, I thought I said 3080. 3080. I don't have that. You don't have it? Okay, let's get that.
Oh, 30.
Yeah, sorry.
So you don't have that 3080?
No, I do not. Okay. Judge, I'd like to address 3217. These are going to look familiar to Your Honor. It's 570 to 574. So 3217, 570 to 574. I don't believe that we've ever resolved the issue. We've discussed them a couple of times. These are the emails between Beata and Charlotte Laporte. This is the last time I tried to bring it up. Your Honor said, wait a minute, aren't there 4 pages? And I said, let me get that and we'll come back. These are the 4 pages, Judge. I think the plaintiff wanted all of them in if any went in. They start backwards, so you may recall them. They start, on the 573 would be the first one. It's a November 15th email from Beata to Charlotte LaPorte at 9:25 in the morning.
Well, it looks like there's something before this.
Number 4 is just thank you. So,
Yeah, go to 574 so the judge can see it if you don't mind.
yeah, that's just then.
Okay, go back to the.
And then it is Ms. LaPorte's response on November 16th at 10:39 a.m.
Can you go to the 572 page? Can you go back to 573? Go back to 572. I guess I need to go to 571 now. Back to 72. Back to 71. Let's go to 70. Um, 71. I've reviewed it, so now what is it that you are seeking to do?
I'm sorry.
What is it that you're seeking to introduce?
Well, I just wanted the one email, but the plaintiff wanted all of them. So I'm seeking to introduce all of these, Judge. First of all, the communications by Charlotte LaPorte are done from her business email. They are a business record. It's her communicating to Ms. Kowalski in the scope of her employment and role with DCF. So I think that those emails are business records. These emails by Beata are admissions. She's admitting that she was told that she had restrictions. She's admitting their statements of the parties. So I think her emails come in. She admits she didn't read the rules. She admits that she was told to not do certain things. She acknowledges that she will try to follow the rules in the future. Charlotte LaPorte's emails also a prior consistent statement when she was testifying with regard to being the person on the November 15th, 2016 call that was played for the jury where she redirected Ms. Kowalski. So they believe for numerous hearsay exceptions, they also are plan of action, and they're not hearsay. So we believe that they, for multiple reasons, are admissible.
Everything Ms. Krause just stated applies to Trial Exhibit 2123-610. This is the email from Kathy Beatty, party admission, to Charlotte Laporte at her business account that was previously excluded regarding the phone calls. That was excluded. We argued over that strongly. If this comes in, because it's a business account of Charlotte Laporte and it's a party admission, then 2123-610, we move for reconsideration.
Well, I don't, y'all have agreed to that these are authentic.
Yes.
That doesn't mean the hearsay exception for business records has been shown or demonstrated. So I don't see where there would be a hearsay exception that would apply for Charlotte Laporte's statements.
Well, Your Honor, we can recall Ms. Laporte then to testify regarding this is her email, a business email. This is the normal way she conducts her business and how normal way she communicates with persons that she needs, parents that she needs to communicate in her role as a DCF employee, if that's the issue.
What is it that you're trying to get and use? Let's look at it that way.
Sure. This is, there are issues in this case that the plaintiff is raising with regard to, first of all, this phone call. They have testified was Ms. Beatty on the call. We called Ms. Laporte, who testified it was herself. This is confirmation that it was her on the call because she's telling Beata, I had to redirect you on the phone call. So it's referencing that same phone call. That's why I'm saying it's a prior consistent statement. Also, plaintiffs are taking position and making a claim that to the extent Ms. Beatty redirected Ms. Beata Kowalski on phone calls, that was inappropriate, and disregarding the issue of whether she had the authority to do it, this establishes that what she was redirecting her from are the same things DCF said you cannot talk about. You cannot talk about pain. You cannot talk about the case. You cannot talk about her therapies. So it's confirmation that Ms. Beatty was redirecting her to the extent she did in line with the guidelines that were set up and established with this first phone call by Ms. Laporte on behalf of DCF. So it goes to numerous issues that the plaintiff is attacking the defense for doing, including the identity of who was on that call that they continue to maintain despite Ms. Laporte's testimony that it was herself.
Well, the jury doesn't believe her either, but that's a different issue. Your Honor, this is fundamentally sword and shield. They want to focus on the November 15th phone call because of these emails. And then we want to raise the November 29th phone call where there are party admissions by Ms. Beatty, and they want to duck back behind DCF in that instance and say, no, the November 29th call, we can't talk about that. We can talk all day long about the November 15th phone call and put emails in about that. But we can't put in emails about the November 29th call. And Ms. Beatty is clearly here saying, I'm honored at the call, and I have all sorts of issues with the way that was conducted.
Judge, the November 29th?
Let's just put the November 29th so I can look at it again.
Yes, to remind the court, the November 20th, I don't know the exhibit number.
2123-610, please.
The email they wanted in was communication regarding recommendations being made to the court. That is opening up the DCF action. This goes to a disputed issue of fact in the case that they have raised, calling Ms. Laporte essentially a liar for testifying that she was the one on the phone call.
Again, this is not an email to the court. This is an email from Ms. Beatty to Ms. Laporte, just like the one you just saw, Your Honor. This is the same exact circumstance, except instead of being Ms. Kowalski, it's Ms. Beatty.
This is,
Here's where I'm at. With respect to what we're looking at now, which is 2123-610, I continue to maintain that is out. It goes to a Chapter 39 issue, which is a request from the hospital to change the dependency court's order. Going back to the other one, there is no exception to the hearsay for purposes of business records. That foundation hasn't been laid. Now, the statement that that Charlotte Laporte said with respect to who was on the telephone call is a prior consistent statement, which for that small portion
Okay.
is supported by a hearsay exception. So that portion can come in. It goes to a specific issue in the case. Now, let's pull that email up and see if there's any fair way to redact it.
3217.
Well, it starts with, I found no objection with your phone call. No, there's one that I would.
Okay, it says also yesterday when you were on the phone, I had to redirect due.
Yes.
Let's see the next page.
Oh, here it is.
Well, Mr. Whitney, at this point, I'm thinking of just letting that one sentence in. I mean, obviously, the header saying who it's from and who it's to.
In the future, if my have which
Can you put 572 and 573 up together?
In which sense? I'm sorry, Your Honor.
Okay, down on 572, where it starts with also yesterday.
Understood. And so
So we would redact out everything after hello Beata until you got to also yesterday, and then the next sentence in the future, that to Ms. Laporte's signature line would be redacted.
But we're redacting in the future?
So,
I'm just
Your Honor, if I go back to understanding where the court is with this, I go back to a position that we discussed, I think it was last week, which is it is prejudicial to us to only include Ms. Laporte's communication in this regard. So if this 4 pages are coming in piecemeal fashion, then we would insist that Beata Kowalski's communications regarding her compliance, her intended compliance, her notification that she didn't get the rules because she sent them too late, etc., also come in.
Well, what I was going to say is that one sentence, I think, is supported by a hearsay exception, which is a prior consistent statement. Now, if you want under a rule of completeness theory all 4 pages, that's a different issue.
Yes, we would, except I think there are issues with, perhaps, I haven't sat down with this email, but I think there's probably issues that still wade into Chapter 39 territory. So, rule of completeness, maybe with certain redactions, but if we're going to let this in, we request the entire exchange come in under rule of completeness.
That's fine, Judge.
Well, then why don't you look, Mr. Whitney, to see if there's anything from a Chapter 39 perspective that can be selectively redacted. Okay?
You can do that tonight or now?
I think tonight.
Yes, Your Honor, I'll do it.
Because this is something for tomorrow.
No.
Well,
okay, we'll do that. Thank you.
thank you. But I'm giving you the choice of just having that one sentence or the balance of it. What's next?
Do you want to do more?
Let's go another 10 minutes and then let's call it a day.
We want to do our objections. All right, let me see. I don't think there's anything.
Oh, the video? Okay, 3080 is ready.
Oh, 3080 is ready, Judge.
3080, let's put it up, please. Hold.
This is 5/17/16, Jeff.
Well, we already have something like this.
The one that they put in is she's in a wheelchair. Clearly, she's moving her legs. She's getting up and down, showing use of her legs.
Well, she's on her knees, but you already have videos with her on her knees.
Well, she's moving from a sitting position up to her knees.
Well, I mean, we have a couple of the dog videos and with her getting onto her knees.
This is pre.
This is pre. No, it's not.
5/17/16.
16.
Okay.
Before the hospitalization, Judge.
The
The puppy one is after the hospitalization.
5 months after.
When was the other music video?
The one that the plaintiff put in?
July 2016.
That's enough music videos. So this one's cumulative.
Okay. Judge, we didn't, I don't recall what happened to 3054, 116. The plaintiff had an objection to page 609, and pardon my short-term memory loss, but I don't recall if the court ruled on page 609 of their objection. It was the one that had the various, do you recall? It had the various comments.
I'm not sure which.
Put it up in
It's the Venice High School, page 609, that had the various, you objected to the one page. 3054.
Can you give us the number again? The clerk wants to know the number.
Sure, I'm sorry. 3054. And then it says page 609. But I think that was the Bates number we figured out.
ID only, okay.
Okay. So this was the one, yes.
Oh, this is the one where
Yes.
I was wondering whether RN is actually the initials
Yes.
of a person as opposed to a nurse.
Yes, I just didn't know if the court had ruled on this. I didn't have any notes.
I have not let it in.
Okay, so that's fine. So for the record, 3054, the objection is to page 0011, and the court is sustaining that objection. Is that correct?
I have not let it in.
Okay. But my understanding is the rest of the exhibit is not objected to. Is that correct, Mr. Wheaton?
I haven't looked at the rest of the exhibit. Is it grades? If it's just grades, we don't object. If it's other counseling notes, we may object.
You did previously say page 609 objection only.
Well, what's page 12? And what's page 10?
Yeah, the rest are just
I think the rest are just grades.
I mean, on the proviso, the rest are just grades. We don't object.
Can someone just check that before I
We'll check it before the morning, Judge.
officially let it in?
Yes.
You have 5 minutes left. Anything else?
Let me look real quick, please, Judge. I think, yeah, I need to, based on, of course, rulings, I don't want to take the court's time up and look at some photos we had to make sure We're just going to remove.
So that's where we're stopping today?
Yes, sir.
Tomorrow, we're going to start 15 minutes later, so 8:45 tomorrow, 8:45. Okay?
Yes.
We'll be in recess, 8:45 tomorrow.